Hello, everyone. Welcome to the Newborn Screening Forum for SCID. This evening, we will be discussing SCID, Severe Combined Immunodeficiency, and some updates to our to the program in association with this. So we're very pleased to be able to offer this forum and it's continuation of professional development for everyone. And as we add new conditions, this becomes even more important. I'd like to first acknowledge our country and the elders past, present and emerging. And my personal wish is that all children have the same benefits and health outcomes, irrespective of where they live in Australia. Importantly, I'd like to acknowledge that our newborn screening program for Victoria is funded by the Department of Health, and we work very closely with the Victorian Department of Health to make this program successful, and are very pleased to be partnering with them. Tonight's presenters are Dr. Mercy Thomas, who is our new support educator, Miss Joanna Kelly, who's going to give a clinical case study from the parents' perspective, and I'd like to really very grateful for Joanna to be part of this forum. And then we'll have Dr. Sharon Chu from RCH Immunology. And finally, we'll finish up with a panel discussion. And Sally Morrissey, who's known to all of you, will be part of that panel discussion, looking at SCIDs at the end. To do that panel discussion, we have some question and answer buttons that you can add your questions to, and I will moderate that. Now, my name is Rhonda Greaves, and I'm the Deputy Head of Biochemical Genetics and the Newborn Screening. And I'm very pleased to have you all here. As the learning objectives are quite easy and clear, we will look at SCID screening for mothers, and from 2 weeks ago, SCID screening has gone on to our weekly reports, and we will also have some referral reports. We'd also like to discuss the significance of newborn screening and the sample collection and the importance of that in the process of adding all of these conditions. And we'd like to be able for you to explain those changes reporting to your colleagues. Newborn screening over the years has changed. We have 58 years of screening. We've screened for 3.7 million babies so far in Victoria. Up until 2022, it was well spaced out, the onset of new conditions. Now we're in a period where we're doing condition after condition implementation. So we went background pilot for SCID and SMA in May 2023. This meant we started screening all babies from this point and developing our assay and background work in assistance, in particular with Sharon Chu and EpiU from the SMA group. For 2024, our project will be galactosemia, and there is more to come following this. And partly this started in 2017 with the Newborn Screening National Policy Framework for a more consistent approach to screening and how conditions might be implemented. And this was ramped up further in association with the Albanese government's pledge to make screening consistent around the country. And I've just got on the right-hand side here some of the next conditions that will likely come in. So these are undergoing advice at the moment for X-linked ALD and sickle cell disease. So there's a lot more work to do, but these are probably coming in the coming years. From the point of the government where we say we are going to implement, we actually have quite a lot of work to do. So including that background pilot that we were doing with the SCID screening as the example. So from the point of time where we're asked to actually implement, there is a number of steps involved. And so from that point of going forward to the formal going live, it does take some time. I mean, I've just got on here some of the things that we have needed to do for SCID. But as we introduce more screening, we actually also need to look at the quality of the sufficiency of our blood on our cards. And traditionally, we've advertised that we will accept 2 to 3 spots on a card, but we've been updating our advice to actually say, please try and fill all spots now. And on this point, we've developed a new collection video, and Joanne Northfield, who's not in attendance this evening, has been really instrumental in doing this. And also Mel Curry, who's in the background here, have really supported this video. And on this note, I'd like to hand over to Dr. Mercy Thomas to introduce this video. Thank you.
Thank you, Rhonda. I am one of the newborn screening educators working alongside Sally Morrissey, and today I'll be presenting the video on the blood collection for newborn screening test. Why I am emphasizing this is because watching this video is to highlight the significance of correct blood sample collection. With the introduction of more and more tests included in the newborn screening, and also with the existing newborn screening card, it is important that adequate and appropriate sample collection is required to facilitate all the analysis. Otherwise, we may have to facilitate repeat sample collection to avoid any diagnostic delays. So in Victoria alone, we know that over 80,000 babies are born annually. And with approximately 80 of these newborns are diagnosed with one of these conditions. So let's do our best that we can to save these newborns in a timely manner, and we do not need an extra blood collection. So let's watch this video. Mel, can we have the sound of the video, please?
You may need to talk to the video, Mercy.
So we can see that how the midwife is holding the baby's foot, and also the appropriate areas that we can approach to get the blood sample. So obviously the first one has got serum, so that will be taken out. So you can see how one large drop of blood can fill that whole space. So that's the right way of collecting the sample. And if we can fill the whole space, that facilitates a good analytical approach. Thanks to Royal Women's Hospital for facilitating this video, and the midwives from Royal Women's Hospital. Thanks to all the leadership team there.
Sharon Chu. I am an immunologist at Royal Children's Hospital. I work in the clinical department of allergy and immunology, as well as the immunology laboratory at in the laboratory services division of our hospital. So I thought I'd just start first with telling you about the test and then the conditions. So this test that it has now been included is called TREC. It stands for T-cell receptor excision circle. And most of you would recall that of your lymphocytes, the vast majority are T cells. And whenever a new T cell is made, very early on in the development process, there is genetic material of the T cell that undergoes changes, including some cutouts, hence the excision terminology of that piece of T cell, piece of DNA of a new T cell. That is used in the screening tests. So there is a PCR that is now being performed in our newborn screening lab that detects this circular piece of DNA that's been cut out of each developing new T cell. So this screening test then logically is very useful in detecting severe T cell defects, because you have to undergo this process. The T cell needs to undergo this process to develop into a good functioning T cell. So if you have reduced TREC, that means that you won't be able to, you lack that ability to make a functional T cell. And there are two main conditions that this test is for. One you've heard about from Joe, severe combined immune deficiency, and these patients lack the functional T cells in their blood. But equally, very similar condition, which is called congenital athymia, because those very early T cells are developing in the thymus. So it's the classroom. And if the classroom's not there, none of this will happen. So there is not, cut out of the T cell receptor excision circle, and there is no fully developed T cell that functions well at the end of the process. So the schoolhouse also needs to be in order. And if it isn't working, the T cell doesn't know what to do and doesn't develop well. So if you get a positive TREC newborn screening result, so an abnormal result, there are a few possibilities. Remember, it's a screening test, so it's not absolutely right all the time. So one possibility is actually the immune system is fine. So that may be, let's say, 10%-ish of the time that you have this positive newborn screen test. But of course, the other possibility is that this new baby does have SCID or congenital athymia and has no functional T cells. And that may be sort of 10%-ish of the time. But actually, the majority of the time that we will get a positive TREC newborn screening test, it won't be a SCID. So maybe, let's say 8 out of 10 occasions. This will be patients or infants who have low T cells, whatever the reason, and there are multiple reasons, and that I won't go into. But I guess this is just to stress the fact that this is just a screening test. Further tests need to be performed, which we called second-tier testing. So if there is a positive newborn screening result, the newborn screening lab will inform our clinical team here at the RCH. And depending on where the baby is, so if the baby is an outpatient at home, our department will contact the parents about this and explain some of the things I've just explained before, what a positive TREC result means. Sometimes, though, the patient, the infant is an inpatient for whatever reason. So in the intensive care, for example. So in those situations, our clinical team will inform the inpatient team, wherever they may be, whichever hospital or ward, and discuss the result and discuss the second-tier testing. And then depending on those results, we will follow up the patient as required. So what is the second-tier testing? It consists of the full blood count, and as I mentioned before, most of your lymphocytes are T cells. So we want to quantify the lymphocyte count. And then we want to subdivide those lymphocytes into the T cells and the other cells, which are B and NK. So that's called lymphocyte subsets. And not only that, we want to know that these are good T cells that have gone through a functioning thymus. So these are well-developed T cells that we call naive T cells. So there is a test for that. There are 2 labs in Victoria that offer this for babies, the Royal Children's and the Monash Medical Centre, with appropriate reference ranges for this young infant group. Of note, if you are contacted and we liaise with you with the second-tier testing, the samples are time sensitive, so the cells must be preserved and not dead or whatever in the tube. So we need to test within 48 hours, otherwise the cells deteriorate, and we want to quantify these T cells. So much of this is discussed in this guideline that's been written by our Society of Allergy and Immunology that was published in 2020 in preparation for newborn screening. I'll discuss a little about the management of a baby where we have diagnosed a SCID at birth in the era of newborn screening. So we need to get on with supportive care. So we start prophylaxis, and Joe mentioned those some of those medications. The cotrimoxazole is to prevent a nasty infection called pneumocystis, and we also provide some immunoglobulin replacement to protect against particularly bacterial infections. We do not give live vaccines because a patient with such a poor immune system will not be able to handle live vaccines and will become unwell. We will make sure that if the infant requires any blood product, that it's CMV negative and irradiated, because even that teeny bit of a CMV that can be in the cells of a blood donor, a blood pack, can be very problematic for an infant with SCID. We recommend no breastfeeding if the mother is confirmed CMV IgG positive, given even, as I said, tiny amounts of CMV will be problematic in the infant. And if the patient should require admission, we recommend some local, depending on the local hospital, that there are protective isolation guidelines, such as single room, wear masks when you come in, if you've got cold sores or if you've got diarrhea, stuff, remember you don't go in, etc. So worked out at the local level. what you saw with Joe's story is we have curative treatment for this condition. The reason being, these are defects of the development of T cells that are in the blood. So a bone marrow transplant will provide new T cells that will grow to be the patient's new immune system. So what we do early on, we would be asking you if you are in this situation with a positive newborn screen baby, we would try very hard to organise already HLA typing of the infant, but also the parents and siblings, so that we can proceed with planning for a bone marrow transplant as soon as possible. So I wanted to sort of tie this back to Joe's story, the science, if you will, with how this played out with Joe's two boys. So I met her first baby in the intensive care. And it was, as it always is, the first day of a 4-day weekend, long weekend, Christmas. She mentioned Christmas, and this was the call from intensive care. Very rapid respiratory deterioration. The third chest drain was going in, and they noticed the low lymphocyte count. Could this be SCID? And for an immunologist, with that story, alarm bells, and really had to action the diagnostics that same day, which we did. But even though you rush it and get the diagnosis so quickly, really difficult to treat when there is already infection. And in this case, sibling one, there was CMV virus and pneumocystis. We have high-dose cotrimoxazole. We started that, all the treatment started within 24 hours. Immunoglobulin to prevent, other infections, and specific anti-CMV antivirals were started. So that's how we managed, that was the acute management, if you like, of sibling one. Sibling two, completely different. Screened, we knew at birth. So we really, went through the guidelines, protective isolation, all that Joe has described. No breastfeeding, no live vaccines, started cotrimoxazole, fluconazole for antifungal prophylaxis, and subcutaneous immunoglobulin as prophylaxis. Unfortunately, there is no prophylaxis as such, antiviral prophylaxis for CMV. So very important to be quick to transplant, which we were able to do. So admitted at 5 weeks-ish. For the workup, the necessary pre-transplant investigations, and the central line needs to be placed, those sorts of things, and ready for transplant at 7 weeks. And we achieved our goal that sibling 2 was virus negative. We are very proactive with regular viral monitoring until transplant. So through that, then we had an uneventful transplant period. And so, that I guess, results in very different outcomes for sibling 1 and sibling 2. Sibling 1 increased the dosing of the antivirals, added more antivirals, but could not get on top of that CMV viremia. There was, despite being on these antivirals, development of severe CMV retinitis. And the lungs, we could not improve. We kept having multiple pneumothoraces, and we found our patient increasingly difficult to ventilate and oxygenate. And due to the worsening respiratory status, we needed to withdraw care. And that is in, complete contrast to sibling 2, who was discharged home at 2 months after transplant. Within 12 months, he had normal number of T cells and normal number of naive T cells. And he's now 3 years post-transplant. He is essentially, full donor cells, so full replenished new immune system, and is now on just yearly from, almost daily outpatient review post-transplant to yearly review by the bone marrow transplant team. So this is what we want to achieve with newborn screening, these outcomes for sibling 2. So I am not seeing sibling 2. I think that's a good thing. He doesn't need an immunologist because he has a completely normal immune system. And from my point of view, it's such a joy to see these outcomes. Thank you. I can't remember who I'm introducing. Rhonda, you might have to take over.
I will take over. Thank you very much, Sharon. And it's time for everyone to turn on their cameras, please, because we'll move to the Q&A session. So thank you. Sharon, you can stop sharing your screen too. Thanks. All right. Thank you, everyone. James, would you like to pop your camera on too? Dr. James Pitt is in here as well. So pop your camera on and we're, I think, ready to go. So we have some questions. I'll just start with some comments from the question, which aren't really questions. There are a number of comments to Joanna for thanking you for sharing your story. And there's part of her story will not be part of the recording that's put up with VCGS. So it is, we're very thankful for you to share it. It really does put what we're doing in perspective. So thank you. And that was a summary because that's come back from a number of question and answers. I'll start at the top. There was some questions, a question about sucrose and I believe pain management with the collection video. Is that something that Mercy or Sally would like to talk to? If not, I can.
Sally, do you want to say something?
No, maybe you were part of that.
Yeah. Sucrose is commonly used for any painful procedures in the hospital to help the newborns to feel less painful. And there is quite a lot of RCAs and other research studies have done on having to use sucrose to reduce pain, especially if parents are not around. And if mom is there, if mom is breastfeeding is another source of reducing the pain. So sucrose is something that at tertiary level hospitals we use to help the child to have less pain whenever they have procedural pain management therapies.
Thanks, Mercy. So I've got one for Sharon here. What's the incidence of athymia in Australia? You're on mute, Sharon.
I don't remember the numbers exactly, but it works out roughly 1 in 10 years here. So yeah, so that's about 1 in a million. So in Australia, yeah, that works out to what, 1 every 3 or 4 years. Rhonda, I don't know the numbers, but yeah, it's roughly. Yeah.
One every 5 to 7 years, I would think. I'd probably that would be it. So this one might be for myself or might be over to James, actually. We throw you in, James, here. And would a positive trek ever be a recollection, or would it always be escalated straight to RCH allergy immunology team? So that's for, I think, James or myself to.
It would always be a referral to the to Sharon and the immunology team, because obviously there's that time critical element that Sharon mentioned. So yeah, we need to get onto that very quickly. As having said that, in newborn screening, there are always some sort of greyness about it when you're looking at so many babies. So we take a pretty conservative approach, though, and if we have any doubts, we'll consult Sharon, and often they'll end up being a referral, even though they don't typically look like what we'd expect with full-blown SCIDs.
There are some babies that where we think there is an interference in the assay, and it's part of the PCR process. And so we know heparin interferes, and we know some preterm babies and some sick babies can be a bit noisier, as we would call them, and we do recollections for that. And at the moment, we put those under any query interference. And it really does affect the trek, as distinct from the SMA part of the screening. So we will ask for a recollection. We're going to review that, whether we'll keep on that query interference, or whether we will do a recollection letter that's specific for the trek. So we haven't made a decision on that. There is the odd one that we are doing recollections on, and that we have been in the background. That is because of interference, and they come back and they're normal on the recollection. So the next one, what is the chance of a false negative newborn screening result? So I think this is where we're saying we have normal TREC levels on the newborn screening, and it could be a SCID. So I might hand this one to Sharon for your thoughts.
Yes, I'm happy to take that. There are what we term leaky SCIDs, so slightly milder SCIDs. So you'll never pick all of them, whatever cutoff you use. But I guess our aim is to diagnose all the complete SCIDs where the T cells do not work at all, or there are no T cells. And there are some other types of SCID that are not covered by this test, where there is a very important molecule on the T cell. So the T cell is there and does function, but the molecule is important in signaling to other cells, for example, and it's not there. So it's just another type of SCID. So I think it's still important for clinicians to not say, oh, newborn screening test was normal. I've got a sick patient in the ICU with low lymphocyte counts and needing chest drains, not to still think of immune deficiency and still test. So I think the newborn screening test will have a very good pick up for what it's been designed to do.
Thank you. Joanna, well, there's a question that I think is for you here, and it's about the antenatal screening that you undertook. Could you describe that a little bit more? How?
Yeah, absolutely.
Thanks.
Sorry, I actually didn't go into detail on a lot of things I meant to because I was flustered telling that whole story. But yeah, so basically we knew that I was the carrier of X-linked SCID we had learned that while we were caring for my firstborn son. And so we knew that we had the potential. So X-linked SCID is boys only, obviously, and it only then has a 50% chance of taking place. Sharon can talk more medically about that. So basically we had a 25% chance. So we did, I think it's called intercept. Sorry, I can't even remember. We did the, amniosis and all those sorts of things because we knew that we had, a high chance. And just on that, it was actually a very difficult thing for us because you can't, obviously there was no point testing until we knew whether it was girl or boy, because if it was a girl, then we were home free. And then when it's a boy, you actually have to wait a few more weeks post 12 weeks to do that test. And then you have to wait a week or two for the results. So I just wanted to share that because, I think there's this sort of perception that, oh, well, if it turns out to have a disease, you could just terminate or whatever. But let me tell you, like, as a mother who's like very supportive of terminations for people that need and want them, was not even close to being able to consider it at that stage of my pregnancy, given my history, and was extremely grateful actually to the Mercy Hospital for helping provide that testing for us.
Thank you, Joanna. We're on 2 minutes past the hour, and we've got one more. I think I can group them together very quickly, Sharon, for you, so we can cover these. It's about athymia and SCIDs. Can you get them together? So a baby born with SCIDs can survive, but if they had athymia too, is that incompatible with life?
There is thymic transplant that I didn't go into. So there are treatment options for that. It's not a complete cure, but in that long term, the patients are still left with lower T cells, but they're definitely there and they're functional. And so, so they still have good outcomes. So there are treatment options for that. It's just different.
Thank you.
Sorry, I just want to add one thing about that testing while I was pregnant. Obviously, that was critical because it gave us the time that we didn't have with my firstborn to find the match. That's why, in case that's not obvious, that's why it was critical to have the testing done so early, because not only was it COVID and all the borders were shut, which complicates an international transfer of goods, but also because the bone marrow donor base, I guess if that's what you call it, is vast. And yeah, so that's also early diagnosis for everybody is important. Yeah. Thanks.
Thank you. Thank you. And I think that's a really good note for us to finish on. I'd like to thank Joanna in particular, Sharon also in particular, Mercy and Sally and James for being here, and for everyone for joining in. This will be available online as a recording, with the exception of Joanna's story, which will be cut out of that. Thanks everyone for attending, and I hope it's useful. Please reach out to Sally and Mercy for ongoing education as you need. Thank you.